So if you're new to treatment planning, there are three basic phases. And again, there are 1,000 ways to do a treatment plan, but most people do three phases. The first is the early phase, where you're definitely reducing any crisis or dangerous behaviors like self-harming, suicidal ideation, that sort of thing. And you're going to begin to start addressing some of the presenting issues. So maybe if you've got a family case and there's parenting, child conflict, you're going to, find an area where you're going to start, addressing, maybe increasing the parental hierarchy sort of thing. But the middle is the working phase. And this is where, in most cases, most people will consider the working phase is where you are addressing the presenting issues. You are those presenting symptoms. And so you're going to be addressing some of the core dynamics that are driving the symptoms. So if there's a lot of, let's say, negative self-talk, you would be reducing that to improve depression or reduce anxiety, that sort of thing. With couples and families, right? The core dynamic may be enmeshment. It may be, so you might be working on boundaries, or you might be working on hierarchy with parent-child. You might be working on improving attachment, right? So it's more of a core dynamic that's going to fix the symptom in the middle phase, okay? The late phase, this can vary from theory to theory, but you're usually, so many of the theories have long-term goals that are unique to that theory, like intergenerational Bohemian therapy. You're increasing differentiation. That is a long-term goal with all of your clients. Satir family therapy, you are, improving congruent communication. So this is what's happening in the late phase. And some theories are very specific with these, and others are less specific with these. But normally you're going to want to make sure that developmental tasks are met for everyone in the family system, couple system, or even individually, and that there's relational stability, whether you're working with an individual or a couple or family. Yay. And of course, long-term wellness, preventing relapse. Awesome, awesome. Godfrey is here. Awesome. Oh, wow. Another from the CSU system as well, another professor. Congratulations and thank you on behalf of all your students for it's a tough job being a professor in the 21st century. So, and I'm glad you love my book, and I hope you find those videos that are free to faculty to stream to their classes, hidden deep, deep, deep in the bowels of the Cengage.com instructor's website. You got to pull up the ebook to find them. So awesome, awesome. Great to have you here. Okay, so writing useful client goals. So let's look at how we're going to do some of this. So I have a 5-step process. The first is the case conceptualization, clinical assessment. It's in my textbooks. There are YouTubes for it. Addressing those crisis and major pressing issues. And then there's developing the 2 to 3 themes from case conceptualization and clinical assessment. We'll be looking at some of those long-term theoretically informed goals, like increasing differentiation, clearing boundaries. And then I'm going to give you a formula for how to write a useful goal. Now, note to anyone who is a student here, we got faculty here, like in my forms, I actually have words typed in there. You should not change these. Nonetheless, I would still have students turn in things. Instead of writing a goal, they put an intervention. So please, 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 if you are having someone grade your treatment plan, look at my templates, use the verbiage. There is a formula, and a goal has to start with a verb, increase, decrease, or some variation thereof, but something has to change. So, but doing an enactment is not a goal. It's not a goal. That's an intervention. A goal is you're changing some core dynamic for the client. So, but please use my formula. I would sit there and students in my class would not use the formula from my book that I gave them in the lecture. I was like, oh my God, I can't even give you half credit for it because it's not even close to a goal. So please, please, please pay attention. And we got faculty here. So hopefully, uh, yeah, hopefully you all will get better goals. Okay, so step 1 and 2 is to identify the the dynamics and issues. So there is a case conceptualization. I have theory specific ones. I have cross theoretical ones. I have for all the counseling therapy theories, or all the major ones, all the major MFT ones. They're all free. On my website, the therapythatworksinstitute.com/books, you got to put your name in the little form and you will get to a web page where you can download them all for all the different theories. And there's cross-theoretical ones that really goes deep, and there are theory-specific ones. Lots of different ways to do it, but this is really important. I also have a clinical assessment form on that same page. And so they are detailed and but they really help you kind of think through things. And if you're studying for licensing exams, those samples that are in my textbooks are really very useful. Step 2, make sure you think about crisis issues like abuse, trauma, substance abuse, self-harm, eating disorders, medical issues. You want to make sure your client is stable before we start digging in too deep. So step 2, making sure that your clients, are in a place to focus. And then after this, you're going to ask yourself, what are patterns are emerging across in the case conceptualization, and how do these fit with clinical assessment? So you might find attachment and boundary issues, let's say in your case conceptualization, emotional reactivity. And then, how does that fit with the clinical assessment in terms of depression or anxiety? For example, you might be working with a couple where you might find that there is a lot of enmeshment in the couple and there's, anxiety in the individuals. And so that's how those two things can kind of fit together. And then the most important thing, if you can learn to do this, you will be a great clinician. And this is the most important thing, is to identify those core dynamics. And you want to have about 2 or 3 typically is what you will find. Here's where I recommend you use theoretical language. And so here are some examples of what these core dynamics could be. You could have the pursue versus and distance pattern in relationships, right? You can have the over-functioning, under-functioning. You can have that in relationships. You can actually have it in your own life. You can over-function at work and under-function at home, right? So that dynamic can happen also in your life. You can have negative self-talk, negative beliefs and schemas, however you want to call it, blurred boundaries or distant boundaries, or you can have a reversed hierarchy in families. You can have insecure attachment patterns. You can have a personal agency, looking at congruent emotional expression, so the humanistic approaches, looking at the effect of dominant discourses. There are lots of ways to identify core dynamics depending on what theory you use. And this is a tricky thing. One of the things I think you will notice is that most approaches, not all, but most will have a complementary pattern, like this pursue distance, over-functioning, under-functioning polarities in a lot of the humanistic approaches. And someday, when I have more time, I have a couple other books I need to write beforehand, but one of the books I'm going to write is going to be on complementary patterns across all the different theories, because it really is fascinating subject. And so you're often looking at these complementary patterns. In my Therapy That Works Unifying Framework that I teach, I streamline and synthesize it, because most of these theories, even though they call it dramatically different things, right? They're still looking at some really core dynamics. So we can boil this down another level. I'll just tell you, my career has become very strange. I spent most of my career analyzing and teaching 50 different theories in all my various textbooks. And now I'm working on a unifying theory that synthesizes it all together. But so there are these patterns, and I don't care which theoretical approach you choose, but pick one and really understand how to identify these dynamics, because it is what makes you a great clinician, and it really reduces your stress load. And so when working with clients, it's a high stress burnout profession, and your ability to conceptualize is what's going to keep you using that graduate degree you spend so much time and money on and not burning yourself out. So I highly recommend you find ways to really hone this skill. Okay. In terms of the long-term goals, that's step 4 here. You are going to, so the long-term goals are like, certain theories will say health is defined by these features, and so we're going to cultivate these. So some examples are in Bowen, differentiation is in its theory what health is. And so that's always a long-term goal. Structural family therapy has effective parental hierarchy, clear boundaries between subsystems, especially between the parental subsystem and the couple subsystem, making sure individuals reach their milestones. Satir is congruent communication, collaborative has personal agency. So, if you have my textbooks, both counseling and family therapy, you will see all the examples, and there are ones I'm very clear when there are long-term goals that are very stable, and you will find those in my textbook. Okay. So here's your formula, people. Write it down. Write it down. Here we go. You need to start every goal with the words increase or decrease. You can any other verb that indicates up or down, basically. But goals are always about changing something. That's what we're getting paid for. So treatment plan goals, you can just always begin with increase, decrease. You'll see my forms have a toggle, like pick one. If you're doing solution focus, it's always going to be to increase the positive. Okay, that's one theory where it's always increasing. But otherwise increase or decrease. And you're going to say some kind of dynamic. So the dynamic is either psychological or relational. So it can be the negative self-talk, it can be boundaries, it can be differentiation. So you're going to take a concept, a theoretical concept. So the dynamic is always a theoretical concept, and then it's going to be to reduce a DSM symptom. You could write it to increase the opposite of what the symptom is, but I think actually third-party payers prefer the reduce whatever your DSM symptom is. That's the formula, okay? So, doing enactments is not a goal. That is an intervention that you use to support your goal to achieve a goal, but a goal is always going to start with increase or decrease. And please don't turn in a treatment plan to your professor or supervisor that's basically an intervention. So some third-party payers will want you to have a measurable goal. This is where the AI could be helpful, right? This is where, you're going to have a phrase like you're able to sustain a blank amount, of time, positive, a symptom for or ability for a certain number of weeks. So able to sustain positive mood for a period of 8 weeks is a measure that they have achieved whatever XYZ goal is. So sometimes you will add this time period to it. And this is when they really take a long time. And this is what a lot of county agencies like to do. I don't think there's a shred of evidence that this makes you a better clinician, but you often have to do it to get that payment. There is a goal writing worksheet that is surprisingly 2 pages long, but it summarizes everything I just said, where you link the problem to whatever dynamic you assess with the symptoms. You kind of string that together, but it's to help you in the beginning brainstorm what is that core dynamic essentially. And you can get it from the therapythatworksinstitute.com/books page, or just click on the books subpage when you get there. There's also treatment plan templates that I'm going to be showing you. You can download all those for free. Again, from the same website, same page. You just sign up once to get to that page, and you will find the examples are all in. People are loving this. Thank you. Okay, good. You can get all of those from. You have to buy the books right now directly from Cengage.com. But all of my books have theory-specific treatment plans for all of the theories that I am talking about. So, okay, so hopefully you can get what you need from these books and use them. They're at the back. They're called Putting It All Together. I put it all together. Sometimes my students would be like, they would turn in a treatment plan. I'm like, you didn't finish reading the chapter because like the answer to this big assignment was all done for you. You just needed to copy half of it. So please read to the end of your chapter, Putting It All Together. The most valuable part is the treatment plan at the end. So let's take a look and we'll walk you through this form real quick. So this is the long form. There's both a short and a long form of these treatment plans because some of them are more for academic purposes. You wouldn't put them in a clinical file. But again, you're going to need your name, your date. Usually you're going to hopefully use a client number, not their name. And if you're using a theory, if it's theory specific, you can write that out. The modalities you plan to use, so individual, adult, child, couple, or family. How often you plan to meet and expected length of treatment. Pretty standard stuff in terms of that. And then this is just a snippet of what it looks like, kind of what we've been talking about. So again, in the early phase, you're managing crisis, reducing the most distressing symptoms. And so You're gonna the type of goal. See, this is a screenshot. It's going to be either increase or decrease, and then what relational dynamic, and then to reduce what symptom. And then here you can see the ability to sustain it for how long. And we'll talk about interventions, but you can put interventions. Typically, most people would expect to see interventions to go with the goal. And this is just a snippet to put on the thing. So in working phase goals, you're going to have the same format and also with long-term goals. So you could, in the early phases, you could have a goal to increase self-regulation, to reduce self-harm, right? That could be a goal. And so a very CBT goal. For the working phase, you could be, increase, boundary clarity or reduce enmeshment of a client, in order to reduce anxiety, that sort of thing. And the long-term goal could be to increase, let's see, increase the clarity between the marital and parental subsystems, right? That sort of thing. Okay. Oh, hi, Vicky. Vicky is just put in a very kind note to me saying I provide incredible benefit to practicing clinicians. So thank you, thank you. I know she's a trainer as well. Okay, we got trainers here. I love it. Okay, writing useful interventions and therapeutic tasks. Okay. So the interventions are how you're going to achieve the goal. And this is where you should be using interventions from a theoretical approach. And so even in my 2-minute treatment plan and progress note, like you want to use theoretical language in your treatment plans and progress notes. This is where you want to use the jargon. Okay. We are professionals. We are jargon experts. We went to graduate school to learn jargon. You read textbooks like mine to learn jargon. Why? Because it makes us professionals. Okay. So you get to use your jargon here. It's okay. I know jargon gets a bad rap, but there's a purpose for it. Because it's insurance reimbursable, folks. So you want to be supporting your therapeutic tasks or each client goal with an intervention, and you really want to use your therapeutic language as much as possible. This is where the jargon comes in. And so let's look at so what the therapeutic tasks are. So therapeutic tasks are, like I mentioned at the beginning, so therapeutic tasks are things that you need to be doing, but I don't think they need to go in the treatment plan that you're going to send to an insurance company. So I pulled those out when I first started doing this back in the last century. I think it was 1998. I worked on my first textbook. I kind of put these together like in the early phase, you're building a therapeutic relationship and assessing, and there are interventions for doing that, right? And those are clinical in our mind, but those aren't necessarily what insurance wants to pay for. So I pulled these out as therapeutic tasks so that you have the true clinical client goals, and those are what you would normally send to an insurance, and the therapeutic tasks are what supervisors want to make sure, and just to help you think through how to use this theory and to take that theory that's so conceptual and put it into practice. So so this, yeah, these have theoretical languages, how each theory creates a therapeutic relationship, uses different interventions and different language. And so you want to be thinking about that, as you're putting your treatment plan together to just see how all those parts actually unfold, in real time, right? So you got the postmodernists who'll be talking about doing collaborative, and you have like, let's say Minuchin, who's joining the family system, right? So you got different languages, different ways of thinking about it, and these therapeutic tasks kind of force you to sit down and connect all of those dots. And like I said, if you're in grad school or taking a licensing exam, this is really helpful. But the three most common ones are going to be establishing the therapeutic relationship, case conceptualization of individual, family, and social dynamics, and then identifying crisis management and referral. So these are pretty standard. All of these three will definitely happen in the early phase of treatment. Creating a long-term maintenance plan, you could say, is a treatment plan, a treatment task at the end of treatment. And so here are the three treatment tasks that I have on my form. So how are you going to build a relationship? How are you going to conceptualize what's going on? How are you going to handle the crisis and referrals? Okay. So I also have included social location and diversity considerations. And this is just an invitation for you to reflect on how your plan makes sense for your client and who they are as a human being. How old are they? What is their racial, ethnic background, language background, immigration status, gender identity, uh, sexual orientation, education level is actually a real important one, um, to be thinking about ability level, neurodiversity, all of these different sorts of things, to make sure that your plan makes sense for who your client is in the world and that there's a fit in terms of values, as well as just approach and style. Because different theories can be a better or worse fit. And so, on my in my form, I require, right? Folks to think about age, gender, sexual orientation and identity, race, ethnicity, religion, class, and even just region of the country or world, and then other factors such as a school, work, community, environment, that sort of thing. So this just kind of invites you to just think through all of that. And so you can see here is the prompt on the form that you will see. And then we have evidence-based practice and client perspective, the last two here. So, once you've put it all together, this is an invitation for you to just think about what does the research say about what works for this type of client or this type of problem. So you can do a search on either Google Scholar or PsycInfo. You can go to SAMHSA, has a whole website on evidence-based practices. And even if you're not trained, let's say you go to the SAMHSA website and you're not trained in a particular approach, you can at least get a good sense of what the research says works. And, because certain presenting issues, let's say, respond very well to cognitive types of interventions. And that doesn't mean CBT, because I would classify narrative therapy as very cognitive, right? And so psychodynamic has a lot of cognitive pieces in it as well. Whereas something like OCD, obsessive compulsive disorder, responds most of the time only to something very behavioral, right? And so then you're going to be looking at more behavioral approaches. So looking at and just understanding what the research says is it's an important practice, and I think it's an ethical responsibility in this day and age. And then just considering what the client's perspective. I mean, so when you talk to the client about this treatment plan, and a lot of organizations actually have a space for this, or the client needs to sign off on it, is this something that they're in agreement with, right? If you're saying, oh, you've got OCD and you need to do exposure and response prevention treatment, and your client's like, nah, I'm not doing that. That is important to consider. And so this is an invitation to pause and think about, have I told my client basic broad strokes what my treatment plan is? I don't think they need to read, the form the way I've written it. And are they in agreement? Is, going with a more behavioral or cognitive or, postmodern or psychodynamic or humanistic, is it all making sense? Are my goals making sense to them? I think that's real important. Okay. Okay, yeah. And again, some agencies will have folks sign off. Again, be careful with too much jargon, but so being mindful of that context. So here are the prompts for that, and then signing off. Again, this is a form that is designed to be used in an academic or training context, so there's a place for both signatures. Do treatment plans make a difference? I think whether, like I said, life rarely goes according to plan. Treatment rarely goes according to plan. Nonetheless, treatment plans are useful. So it really helps you think through what dynamics need to be changed. It really helps give you a focus. You're going to modify that focus week to week, especially in family therapy. The whole thing of family therapy is you're supposed to be refining your hypothesis of what the real core issue is week to week. So hopefully you're tweaking that conceptualization consistently as you go. And it really makes you more skillful, more nimble. And when things come up, you have a hypothesis that can be revised and fine-tuned and used to make sense of what happens from week to week. And it really helps you walk in there and have a sense of confidence, have a sense of clarity. So you want to have a plan, but you can't be rigid with your plan. To have a plan and be able to let go of it on a dime. Um, and so it's this both and, which is pretty much sums up family therapy, huh? And it helps you ground in yourself in your theory. And so I think especially if you're still working towards licensure and using theory-based treatment plans to really help you understand how theory works is critical if you really want to become good at doing this work. So you can get the forms here at therapythatworksinstitute.com.